Okay. So this is our skills presentation of airway management, and we'll be talking about the proper technique, the proper equipment to use for the patient, as well as suctioning. So this is our mannequin for today. I did get it from the college. If we want to use this, we probably spray this valve a little bit so we have a little bit better lubricant. Our tank of oxygen, we're going to hook up our devices, our BVM, our nasal cannula, and our non-rebreather to the oxygen. And with the oxygen, obviously you know to keep it laying down, but we're going to open it up. You should have at least 2,000 in there. When do we want to change it out?
It gets close to
Less than
500.
1,000.
Yeah. Yeah. So, and this is how we're going to dial out how much we want. So if we want 6 liters for a nasal cannula, then we'll just put it. All right, so to attach it, all we're doing is hooking up the end of the tube to the oxygen tank. So a non-rebreather, a back off mask, how much we're using?
I mean, 15 to 25, but 15 might be sufficient.
Yeah, 15. Yeah, we don't go any higher than 15.
Okay, 15's
Yeah,
max.
yeah.
Okay.
Just gonna fill up your bag. I think this one actually is only 500 cc's, which is nice. We have some of the ones that are bigger ones that hold 1,000. So what's recommended, and I just read this, was squeeze the bag at the end so you're not overinflating the patient and they're getting the adequate amount of oxygen. So with this one, we can just do the whole thing. So you're gonna be putting your oxygen on up to 15 liters. I'm gonna turn it off so that it's not. All right, and then ideally you want to be at the head of the patient, doing a good head tilt chin lift. This is best if we do it with 2 patients, so one can hold it and get a good seal and the other one is bagging, if you have enough manpower to do that. And you're looking for adequate chest rise and fall. See, I don't have the ability to, the strength. I'm getting it, but it's not that strong. So that's telling me that I'm probably getting some air leakage in here. If I hold it, can you bag?
Yeah.
Okay. So at the same time, I'm doing head tilt chin lift, or I could do the jaw thrust. Go ahead. See how much better. And I can still feel a little bit over here. Okay. Okay. So go ahead and do that. We'll just do one at a time and
Right.
doing that CE method, right? One breath every 5 to 6 seconds, over 1 second, looking for good adequate chest rise and fall. Okay.
And it said 15 on this?
Yes.
15.
Okay, good. All right. So nasal cannula, how much oxygen?
6 liters.
Up to 6,
Yeah.
right. This thing is really sticky, it's gotta be really old, so. So go ahead and we'll place it on the patient, hook it up to your O2. Putting the palms into the nose and around the ears. This can dry a patient out as well, so. He doesn't really have big ears to stick everything on, and you can always just push this up a little bit with a joker. That's it? Okay. When will we put a nasal cannula on the patient?
if we need to get their sats up a little bit, or if they say they're having breathing issues.
Does it hurt to put it on?
No, there's
No.
not many, or any contraindications.
A lot of
Yeah,
time it's just patient comfort,
yeah, exactly. You
Yeah.
can put 2 liters on them. And,
especially if they're on homo too, and we have to put them on the cot and take them somewhere, it's a lot more comfort.
Mhm. Okay. You good? I'll take it off and you guys just go ahead and put it on. Okay. I've seen some people put it behind the head, so we want to make sure that we put
The
it on
lasso
the ears.
technique,
Uh,
the lasso technique.
Perfect. Perfect, okay. Next is the non-rebreather. The purpose of the non-rebreather is so they're not rebreathing the carbon dioxide that they are exhaling. The bag will inflate, so we want to make sure that the bag inflates first before we actually put it on the patient. This is so tied up, I can't get it undone here. So for this patient, how much oxygen will we put on them?
With the non-rebreather?
Yeah.
15.
Yeah, you could do 10 to 15. Exactly. Again, watching your patient just to make sure. And it's just a simple mask goes over the nose and the mouth, ensuring that the bag is filled. And on this, you're just watching your patient, look at the saturations, look at their work of breathing. Is it helping them? If not, we can always adjust it. I'm gonna turn this off. I'm not sure.
You blow up the bag.
Okay. Perfect, and the bag is filled. Okay, good. So let's talk about the NPAs, the nasopharyngeal airways. We have different sizes. How are we going to size this to the patient? Going from the tip of the nose to the tip of the earlobe itself. So after a while, you kind of figure out which is going to be best for the patient. Me, I don't know. That one's probably a little bit better. So we want to make sure we lubricate it. You're going to tell the person exactly what you're doing. Okay? And I don't know if I want to ruin the domain, but you're going to take the bevel side and it's going to go along the septum. So tell them what you're doing. Go ahead, just push it straight down. Can actually turn it if it doesn't fit in right. States that you can suction through this. Only a whistle tip is going to fit through this. Nothing else any bigger than that is going to fit through that. Okay. When do we not want to use this?
Trying to the face.
Facial injury.
I think it was only one time that it actually went up into the brain, but you know, it takes one time and that's it. So, all right. Questions on this one? So we measure it, insert it, and we're good. Lubricate it. We're good.
Mhm.
Measure first.
So we have a plethora of sizes that we carry. Good. Good. Explaining to the patient what you're doing, gonna help them out.
Sir, we're gonna put this in your nostril to assist with your breathing. Bevel towards there, septum. There you go.
Perfect. Can we put our non-rebreather on top of that? Yeah, can we
Yeah.
bag them on top of that? Sure. Okay, perfect. All right, the next is the oropharyngeal airway, and what's the purpose of the OPA?
To keep the tongue depressed.
Yep, exactly. Okay, and obviously we have the different sizes. So the measurement is going to be the same. We want to look from here, well, from here to here. In this case, I'm just going to pull this one. Looking, that one may work. It might be a little bit small. This one might be a little bit big. Okay, that one's way too big. So we'll go ahead and use this one. When do we want to use this in a patient?
Unresponsive, no gag reflex.
No gag reflex, okay. So we can either do 180, or I like to start at the top and turn all the way around. For me, that seems to catch the tongue a little bit better. And this will go right at the lip level, okay? If we need to suction, we can suction on the sides of it, both sides. And you can bag, and you can use your non-rebreather with this patient as well.
Alright. Measure. So you did
Mhm,
this,
yeah.
and then you twisted it. Is that what you did?
Yep, exactly.
Okay.
And then turn it. There you go.
Oh, perfect.
I think it catches the tongue a little bit
Okay,
better when you
cool.
start that far.
Okay.
If it's too small, it's going to be below the teeth, and you certainly don't want that because it's not going to be doing the job you expect it to do. Okay. Nice.
I have a question. So,
Sure.
for the nasal, I didn't ask, but if we get to somebody that's already locked,
Mhm.
jaw locked, with no trauma to the head, that's the go-to.
Sure.
Right.
Yeah,
Yeah.
for sure. So next is opiate, the eye gel. And it's a little bit of skill with the eye gel. Now, protocol does state that we can't use an eye gel unless we have an end-tidal CO2 monitor. We don't carry an end-tidal CO2 monitor. But as soon as the medics come, they will take it, either they take it out and they intubate the patient, whatever they choose to do, or they'll add an end-tidal CO2 monitor to the BVM. Where's that?
Seriously, and although we don't have end title, we still put it in waiting for the
Yes, you can, and
Okay.
that's exactly what protocol states. End-tidal CO2 monitoring is mandatory following placement of a BIAD, blind insertion airway device, which is what that will be, once available. Let's see. So we don't have it available to us, so once the medics come, they'll put it on, and that's their job. So the eye gel is based on the basal metabolic weight of the patient, and we're gonna guess how much a patient weighs. How much, I'm just gonna throw it, don't,
You're fine.
okay, how much do you weigh?
230.
Okay, 230, so I would guess 200 if I saw you. So, oops, they all have the weight in kilograms on the back. What I tried to do is
That's nice.
write it in.
That's nice when they bring it on.
Yeah, exactly. These are expired ones, but I do that, I'll even write that on the buggy, so it's so easy for
That's
us.
really nice.
If you can't, if it's not, just multiply it by 2.2. Okay, I just do it by 2, and that way it's easy. Okay, so in this case, you're 200 plus, we would use the orange one, the number 5 on you, okay? I did some teaching over at Brissett Town. They have a plethora of these things, every single size you can imagine. We only carry 3. So we could never put one in a child. even though you're able to put a mesh on. So, let's use this one. Actually, can we use this one just for demonstration? You're gonna open up your packet, set it next to your patient, right here. Not really a good idea to put it on their chest because it's gonna fall off. Open everything up, take your contents out, make sure you have everything available. Some of these, we did find, don't have the strap in them. So if they don't have the strap in them, we'll take them down. But you have to make sure it's secured. So open up everything. In the meantime, somebody's bagging your patient. This, they say, should only take 5 seconds to do. Take your eye gel out. You're going to put the lube right in through here. In that little well. You're going to lubricate on the sides, avoiding the hole here. We're not using that hole in the field because this is really for OR, so they can suction in through that, but we're not going to be able to do that in the field. I also learned, looking at research, to go ahead and do the back of this because that's actually going into the patient. So you're going to be, you can either be behind or ahead of the patient. And you're just going to guide it in. Okay, I don't know why this mannequin is clicking. Pushing it until you feel resistance. It could be this mannequin, so I can't really tell you right now. But this is the bite block on it. They call it the integral bite block, and this is where the teeth are going to be on this. So if they happen to clamp down, they're not going to collapse this tube. Okay, so it's right through there. What I need to do is have somebody verify placement for me. I could do it myself, but it's ideal if we have 2 people do it. So I've got it in the patient. You're going to hook your BVM up to here. You're going to bag and auscultate at the same time. Okay, so you're listening. Do you see chest rise and fall? I'm hearing air in here, huh?
Very little,
Yeah.
just not much movement.
I'm not sure if it's the mannequin there. It is or not.
See if we can.
I don't know what that click is. Okay, so as you're bagging, you're going to listen here, here, and over the epigastrum. If you hear any air in the epigastrum, pull it out. You're going to start over again because you're going to cause this to distend and it's not in the right place. Okay, so we verified placement. Everything is good. Now, I'm not letting go of this. I'm going to go ahead and put this on over under the neck and hook it onto here and here. Okay. Once this is in, it does not come out. If you suction along the side of it, okay? It has to stay in. If you happen to move this and the patient moves a lot, then it has to be re-verified, okay? To make sure the placement is correct. All right, time it. When did you put it in? What size did you put in? Tell the medics exactly what we did. Okay. Questions on this? Do you want me to show you how to tape it? You good?
Yeah.
Okay. All right. I'm just going to put it back the way it was, so I'll throw this all out. When we're all done. Okay. So you come up to the patient, you determine that you can use an eye gel on this patient. It would be the best treatment for an adequate airway on this patient. Go ahead and start. Cap, you can start if you want.
Okay.
Suit your And how did you determine the size you chose?
By the weight of the patient.
Your guesstimate?
I'm gonna put the lube right in that spot.
Let me try this and see if this is going to help a little bit. You go on that or this?
Good job.
Okay.
Alright.
Let's see.
on the sides. Check this. Put it down. Verify. Oscillate. Yep. It's placed right. Hold on.
I like the iGel. I think it's great. I think it's the best airway we can use for a patient.
Hold it down. Check it again. If the patient moves too much, we're moving around, we gotta oscillate again
Mm-hmm.
to verify.
Okay.
All right.
And where can you suction in this?
On the sides.
Good.
Thank you, sir. I'm gonna look at his weight and kind of estimate.
If it was sticking like this far out, would you change it out? If you couldn't advance it anymore, would that tell you what?
Was it blockage?
It's too big.
Oh, okay.
Or if it's further past the teeth into the mouth, then it would be too small.
Alrighty. Resistance. Alright. Look at the area on him.
So try to hold it without letting go of the actual iGel
Okay.
until you get it placed.
Alright.
You hear clear burst sounds on both sides.
Lock ring.
Actually go underneath the neck here.
Okay. Right here.
There you go.
Go for chest rise and fall, oscillating.
And when you suction, where would you suction?
I would go right to the side.
Right, okay. Frank, when you're done, let's leave it in and we'll do suctioning along the side
Okay.
once you're done.
Yes, ma'am. Wait. Keep it up. Check.
Good.
Good.
Tasha.
Good.
Good, okay.
Suction on the side.
So with suctioning, we talked about this, and we want to make sure that you turn it on, check it every shift, just to make sure that it's working, and unless you have the manuals like we have. This one, you want to have it up at least to 300. I would, it's at 350, so 200. So you're going to turn it on. This is your yank hour. Okay, this is your hard tip. This is gonna get some hot dog, maybe not. But this will be easier for vomitus, for sure. So when you're suctioning on your patient, turn it on, obviously. I'm not gonna leave it on right now. But don't undo this, don't move it. And you're gonna suction. Remember, you wanna touch this, so you're gonna get the suction itself. So we're at 300, and you're gonna, we didn't measure here, sorry. From here to here, which means that that's as deep as we're gonna go. Okay, so there's my finger right there, all right? So I'm gonna estimate that, but I also wanna hold it. So you're gonna suction no more than 15 seconds for your patient, and you're gonna do it on the way out. If you have to go to the other side, then suction on the other side as well, doing exactly the same thing. Okay? The other difference is the whistle tip, which is really small. This is the one that you would want to do through the nasal cannula. You can also do it through here. This is going to go inside, this is going to hook into here, and you want to hold over. Okay, so again, measuring from patient here to here, we know that it's not going to go any deeper than that right there. Okay, so as you suction, you've got it in, put it in, then cover it over so you know that you're making the suction. No more than 15 seconds in an adult, no more than 10 seconds in a child, and do it on the way out. Okay. Now I'll leave that one in. Go ahead and
Turn it on, measure, boom, in the side, go down to there, suction on the way out. Let's do the other side. Don't move it. Suction on the way out.
Okay. Good. And with the ink power,
Oh, sorry, yeah. Measure to there, go down far, suction on the way out. Down, suction on the way out.
okay, perfect.
Sorry.
Gonna measure. Okay, we're going into the side. Suction on the way out, no more than 15 seconds.
Okay.
Switch that out. Measure. Okay. Side. Suction on the way out. This side over here. Suction.
Perfect.
Awesome.
Turn the machine on. Measure. Section down, up. Try not to move. And then on the way back up. Down.
This is not what you have on
We
Oh, it
have-
is?
Mhm.
The machine's on. Measure.
Where's the battery? Change the battery.
Plug it up.
Well, I plug it in.
Way out.
Okay.
Try not to move. And on the way out, no more than 15 seconds.
Okay. Now your patient can still be backed at the same time someone's suctioning. Okay. What if it gets clogged? What are you going to do? If we have water available. I mean, usually
Try
we'll
to
have
suck
like,
it. Section.
yeah, yeah. Okay. That's it. Questions?
No, ma'am?
You're good? All right, thank you.
You want everything back on that table over there?
You can leave them there because
Okay.
I have to pack everything up.